I'm glad to be speaking for the GvHD Hub at EHA 2019 and I will be speaking a little bit about new developments in chronic GvHD treatment. So over the last few years there has been some implementation of NIH GvHD Consensus Criteria in the clinical routine. These staging and diagnosis criteria have been developed for clinical trials, but of course because of its importance they have been implemented in clinical practice. However, we are lacking some similar consensus criteria or guidelines in the treatment of chronic GvHD, which of course brings to different clinical practices all over the world, especially according to some surveys done across the European centers in several last years, in last year especially. We have learned that there is a wide heterogeneity in the treatment of chronic GvHD. The only clinical standard that exists still today is first-line treatment with systemic steroids. However, when it goes to progressive onset chronic GvHD, when it goes to steroid-refractory GvHD, when it goes to lung GvHD, a special hard-to-treat entity, there is absolutely no standard clinical practice. Some of the data have shown that also calcineurin inhibitors, in addition to systemic steroids, are being used less as well. This is also due to the lack of data in prospective randomized trials. In those entities that I've mentioned as progressive onset GvHD, which usually happens as a development from acute GvHD when a patient is still on immunosuppression. Still, most of the centers use ECP as well as in lung GvHD and steroid-refractory GvHD. And when it comes to steroid-refractory GvHD, this is a real challenge, and the only standard today is still including the patients in clinical trials. Some recent changes are related to new drugs as ibrutinib, which has been approved, and also due to the lack of data, some of the retrospective studies are also changing the clinical practice, like the use of ruxolitinib. But as I said before, there is absolutely no standard treatment plan for patients with steroid-refractory GvHD, and of course this is the field that needs the most working on from the GvHD experts. I would just like to emphasize two very important points as well. One is development of supportive care in patients with chronic GvHD, development of local therapy, as we know, and this is something that even NIH GvHD Consensus Criteria states, that a patient should be treated as with at least immunosuppressive systemic treatment as needed, because of the complications which come of course with immunosuppressive treatments, which decreases the overall survival in general. And for that reason we have to insist on the development of local therapies, especially in types of chronic GvHD which are maybe most frequent, as iGvHD, as mouth GvHD, which can react very well on aggressive local treatment as well. In order to also improve treatment of patients with chronic GvHD, it is very important to manage these patients in interdisciplinary way, which means a close collaboration and communication between different specialists, coordination from a dedicated GvHD nurse, dedicated GvHD transplant physician, and education of patients from the time that GvHD is diagnosed. And with that, I would like to emphasize that this type of approach also helps in development of new treatment strategies as well. And I would like to emphasize my personal experience with a new treatment approach developed in University Hospital Center in Zagreb for refractory chronic GvHD of the eye. And that is our experience with amniotic membrane transplantation, which is something absolutely new in chronic GvHD management, but something very familiar in the management of patients with ocular surface diseases in ophthalmology. This approach is very attractive because amniotic membrane does not contain HLA antigens, so it can be administered without immunosuppression, without fear of rejection. And it is easily applicable. It is just sutured to the eye, where it dissolves over a week or two, and in our experience brings to significant clinical improvement, especially in patients who have a contraindication for the increase of immunosuppressive treatment. This approach is probably effective for several reasons. Amniotic membrane it serves as a physical barrier, helps healing, promotes epithelialization, and is rich in cytokines, which probably then is important in its prolonged immunosuppressive effect that we have also seen in our patients. So this is a treatment procedure that has been developed in a close collaboration with our dedicated ophthalmologists. And this is an approach that could lead to the improvement in management of patients with severe chronic GvHD of eye, especially in patients who have contraindication for the increase in immunosuppressive treatment.